You take your blood pressure pill every morning. Your reading says 132/84. Your doctor says you're doing fine, but something feels off. You're tired more than you used to be. Your head feels pressure. Sometimes you worry about your heart. And when you mention it to your doctor, they look at your numbers and say, everything's controlled. But you're left wondering, if everything's controlled, why don't I feel normal? I'm Dr. Isabella Morgan, and today I'm going to explain the gap between what your blood pressure monitor says and what's actually happening inside your arteries. Because here's what nobody tells you. Your blood pressure reading is just a number. It tells you the pressure in that moment, but it doesn't tell you why that pressure was high in the first place. It doesn't tell you what's broken in your body that created the problem. And most importantly, it doesn't tell you whether taking a pill to lower the number is actually fixing what's broken, or just covering it up. By the end of this video, you'll understand exactly what's happening inside your body at the system level that made your blood pressure go up, why that process continues even when medication controls the number, and what the difference is between managing a symptom and fixing a cause. Here's the confusion most people face. Your doctor measures your blood pressure. Let's say it's 145/92. That's high. Doctor prescribes a pill. You take it faithfully. Next visit, your pressure is 130/82. Doctor says, good job, keep taking the pill. But you walk out of that appointment with a question you might not even know how to ask. The question is this: did the pill fix what was broken, or did it just change the number? Because if something in my body was malfunctioning enough to create high blood pressure, and now I'm taking a pill that lowers the number, did the malfunction get fixed, or is it still there? This is the gap nobody explains clearly. And it's not your fault you're confused. The way medicine talks about blood pressure makes it sound like the number is the problem. Lower the number, problem solved. But that's not actually how your body works. The number is a measurement of a problem. It's not the problem itself. Think of it this way. Imagine your car engine is overheating. The temperature gauge shows red. You could disconnect the gauge so it shows normal. The number would look fine, but the engine would still be overheating. That's the difference between managing a measurement and fixing what's broken. So, let's talk about what blood pressure actually is. When your heart pumps, it pushes blood through your arteries. That pushing creates pressure against the arterial walls. That's blood pressure. Your monitor measures that pressure in 2 moments. Systolic, the top number, is the pressure when your heart contracts and pushes. Diastolic, the bottom number, is the pressure when your heart relaxes between beats. Now here's what most people don't understand. That pressure number can be high for different reasons. Your blood volume could be too high, meaning too much fluid in your system. Your blood vessels could be constricted, meaning they're squeezed too tight. Your arterial walls could be stiff, meaning they can't flex properly when blood pumps through, or some combination of all three. The number 145/92 doesn't tell you which of these is your problem. It just tells you the pressure is elevated. Now, when you take blood pressure medication, different pills work in different ways. Some pills make your kidneys dump more fluid, reducing blood volume. Some pills force your blood vessels to relax, reducing constriction. Some pills slow your heart rate, so it pumps with less force. The medication changes the number. But here's the question. Did it fix why your blood volume was too high in the first place? Did it fix why your vessels were constricted? Did it fix why your arterial walls are stiff? Or did it just force a change that makes the number look better? This is where your confusion makes complete sense. You're taking a pill, the number looks better, but you don't feel like the problem is solved. You still worry. You wonder if damage is still happening even though the number is controlled. And you're wondering this because somewhere inside, you know that lowering a number isn't the same as healing your body. You're right to wonder this. Research published in the Journal of the American College of Cardiology looked at exactly this question. They measured something called endothelial function in people taking blood pressure medication. The endothelium is the lining of your blood vessels. When it's healthy, your vessels work properly. When it's damaged, vessels don't function right. Even if medication controls the pressure number, what they found was that many people on blood pressure medication had controlled numbers but still had damaged, dysfunctional vessel linings. The medication was managing the pressure but not healing the vessels. So your instinct that something's still wrong, even though your numbers look good. That instinct is accurate. The medication is doing its job of controlling pressure. But the underlying reason your pressure went up in the first place that might still be there, still progressing. So let's start explaining what actually breaks in your body to cause high blood pressure. The first mechanism involves your kidneys. Your kidneys are supposed to regulate how much sodium and water stays in your body versus how much gets excreted in urine. When this system works correctly, your blood volume stays stable, your pressure stays normal, but something causes the system to malfunction. Your kidneys start holding on to sodium even when they should be getting rid of it. More sodium means more water retention. More water means higher blood volume. Higher blood volume means higher pressure. Now, here's what nobody explains clearly. Why did your kidneys start malfunctioning? What made them hold on to sodium when they're not supposed to? The answer involves another mineral most people never think about: potassium. Your kidneys don't just respond to sodium, they respond to the balance between sodium and potassium. When you consume adequate potassium, your kidneys have the signal they need to excrete excess sodium. When potassium intake is chronically low, your kidneys lose that signal. They start holding on to sodium by default. Additionally, low potassium activates a hormonal system in your body called the renin-angiotensin-aldosterone system. This system, when activated, tells your kidneys to retain sodium and excrete potassium. It's a vicious cycle. Low potassium activates a system that makes you retain sodium and lose more potassium. Your kidneys get locked into a sodium retention state. Blood volume increases, pressure goes up. Now here's the practical problem. Studies show that the average American consumes around 2,600 milligrams of potassium daily, but research suggests that optimal kidney function requires approximately 4,700 milligrams daily. That's a gap of over 2,000 milligrams. This means millions of people's kidneys are operating in a chronic low potassium state, unable to excrete sodium properly, constantly activating hormones that raise blood pressure. Now, you might be thinking, okay, so I need more potassium. But here's why this is confusing. Your doctor told you to reduce sodium. You did. You're eating maybe 2,500 milligrams of sodium daily. You're being careful, but your blood pressure is still elevated. Why? Because the problem isn't just how much sodium you're eating. The problem is that your kidneys can't excrete sodium normally because of inadequate potassium. You're restricting sodium, but your kidneys are recycling every bit of it because they don't have the potassium signal they need to let it go. This explains why some people reduce sodium religiously and see minimal blood pressure improvement. Their kidneys are locked. And the lock isn't sodium, it's potassium deficiency. Now, when you take a diuretic medication, it forces your kidneys to excrete sodium. The blood volume drops, the pressure drops. Problem solved, right? Not exactly. The medication is forcing an outcome, but the underlying potassium deficiency remains. The hormonal dysregulation remains. Your kidneys are still malfunctioning. They're just being overridden by medication. Now let's talk about the second mechanism. Your blood vessels are supposed to be able to relax and constrict as needed. When you're resting, they should be relatively relaxed. When you're active, they adjust. This happens automatically through a molecule your vessel lining produces called nitric oxide. When your blood vessel lining is healthy, it produces nitric oxide continuously. This nitric oxide diffuses into the muscular layer of your vessel wall and tells those muscles to relax. Your vessels stay open. Blood flows easily. Pressure stays normal, but something damages the cells that produce nitric oxide. The lining of your vessels, called the endothelium, becomes dysfunctional. It stops producing adequate nitric oxide. Without nitric oxide, your vessel muscles can't relax properly. They stay constricted. Blood flow faces more resistance. Pressure increases. Now here's what makes this confusing. When you're on medication, let's say you're taking a calcium channel blocker. This medication prevents calcium from entering your vessel muscle cells. Without calcium, the muscles can't contract as strongly. They're forced to relax. Your vessels dilate. Pressure drops. Your blood pressure reading looks good. But the underlying problem, the damaged endothelium that can't produce nitric oxide, that's still there. The medication is working around the problem. It's forcing your vessels to relax through a different mechanism, but your vessels still can't relax naturally on their own because the nitric oxide production system is broken. So, what damages the endothelium in the first place? This is where it gets clearer. Research has identified several factors. Chronic elevated blood sugar, even at pre-diabetic levels that doctors might call normal, damages endothelial cells. Oxidative stress, meaning an excess of damaging molecules called free radicals, destroys the enzyme that makes nitric oxide. Inadequate intake of certain nutrients means the nitric oxide production pathway can't function even if the cells are trying. Chronic low-grade inflammation keeps the endothelium in a dysfunctional state. Now here's what makes this mechanism particularly problematic. The damage is self-perpetuating. When your endothelium can't produce nitric oxide, your blood pressure goes up. Higher pressure creates more mechanical stress on the vessel lining. More stress causes more damage. More damage means less nitric oxide. Less nitric oxide means higher pressure. The cycle keeps reinforcing itself. Additionally, a damaged endothelium becomes leaky. It allows things into the vessel wall that shouldn't be there. LDL cholesterol, particles, inflammatory cells. This is how the process of plaque formation begins. So endothelial dysfunction isn't just about blood pressure. It's the beginning of the arterial disease process that leads to heart attacks and strokes later. Now let's talk about the third mechanism, and this one will probably surprise you because almost no doctor checks for it. Your blood vessel muscles, the smooth muscle cells in the arterial walls, they contract and relax in response to calcium. When calcium enters these cells, they contract, your vessels constrict, pressure goes up. Your body has a natural regulator that controls how much calcium enters these cells. That regulator is magnesium. When magnesium levels are adequate, it competes with calcium for the same channels and binding sites in muscle cells. It acts like a natural brake. It prevents excessive calcium entry. Your vessel muscles can't contract as forcefully. They stay relatively relaxed. But here's the problem almost nobody knows about. Studies estimate that nearly half of Americans don't consume adequate magnesium. The typical American diet provides maybe 250 to 300 milligrams daily. Optimal vascular function appears to require 400 to 500 milligrams. Why is intake so low? Because magnesium comes primarily from foods most people barely eat. Dark leafy greens, nuts and seeds, whole grains, legumes. Most people's diets are dominated by processed foods, refined grains, and animal products that provide minimal magnesium. The result is a chronic magnesium deficit. Your vascular, smooth muscle cells are operating without their natural calcium regulator. Calcium enters freely. The cells contract excessively. Your vessels stay constricted. Blood pressure stays elevated. So now you can see the complete picture of what's broken. Your kidneys can't excrete sodium properly because of inadequate potassium intake activating hormones that lock them in retention mode. Your blood vessel lining can't produce nitric oxide properly because of damage from oxidative stress, inflammation, and nutrient deficiencies. Your blood vessel muscles contract excessively because of inadequate magnesium allowing too much calcium activity. These three mechanisms interact. The kidney problem increases blood volume, which increases pressure, which damages the vessel lining more. The vessel lining damage reduces nitric oxide, which means vessels can't relax, which increases pressure further. The magnesium deficiency allows excessive constriction, which increases pressure and damages the vessel lining even more. They feed into each other, creating a downward spiral. Now, when you take blood pressure medication, it interrupts this spiral at one or more points. A diuretic forces sodium excretion despite the kidney dysfunction. A calcium channel blocker prevents vessel muscle contraction despite the magnesium deficiency. An ACE inhibitor blocks part of the hormonal cascade despite the underlying potassium problem. The medications manage the outcome. Your blood pressure number improves, but the three underlying mechanisms remain broken. This is why the medication has to be taken continuously. This is why you feel like something's still not right. Even though your numbers look good, your instinct is correct. The mechanisms are still dysfunctional, but there's something even deeper happening that your blood pressure reading doesn't capture. Over time, the combination of elevated pressure, endothelial damage, magnesium deficiency, and chronic inflammation causes your arterial walls themselves to change structurally. Calcium starts depositing in the walls, not just affecting muscle contraction, but actually accumulating in the arterial structure itself. Your arteries begin a process called calcification. They're literally becoming stiffer, less flexible, more like bone. When arteries are healthy and flexible, they expand slightly when your heart pumps blood into them. They absorb some of the pressure force. Then they recoil, helping push blood forward. This keeps both systolic and diastolic pressure moderate. But when arteries become stiff from calcification, they can't expand. All the force from your heart's contraction slams directly against rigid vessel walls. Your systolic pressure spikes higher. Then when your heart relaxes, stiff arteries can't recoil properly. They can't maintain forward pressure. Your diastolic pressure drops. You develop what's called increased pulse pressure, a large gap between your top and bottom numbers. This pulse pressure, this gap between systolic and diastolic, predicts heart attack and stroke risk better than the individual numbers themselves. But almost no doctor talks about it. They focus on getting your systolic under 130. They don't discuss whether your arteries are becoming progressively stiffer while the numbers look controlled. Here's what makes arterial stiffness particularly problematic. There's no medication that reverses it. Think about the medications we discussed. Diuretics reduce blood volume. Calcium channel blockers prevent vessel muscle contraction. ACE inhibitors block hormonal signals. Beta blockers slow heart rate. None of these medications remove calcium deposits from arterial walls. None of them restore flexibility to stiffened arteries. They manage pressure despite the stiffness. They work around it, but the stiffness itself progresses. There's actually a test that can measure arterial stiffness directly. It's called pulse wave velocity. It measures how fast a pressure wave travels through your arteries. In flexible arteries, the wave travels slowly. In stiff arteries, it travels fast. The faster the wave, the stiffer your arteries, the higher your risk. This test exists. It's non-invasive. It takes 10 minutes, but almost no doctor orders it. Why? Because if they measure it and find it's elevated, they don't have a medication to prescribe for it. So they don't measure it. They focus on what they can treat with pills, the pressure number, not the vessel quality. This means you could have blood pressure of 128/82 on medication numbers that look perfect while your arteries are progressively stiffening. Your pulse wave velocity is increasing. Your actual cardiovascular risk is climbing and nobody's measuring or addressing it. So now you understand why you're confused. You're taking medication. Your numbers look good, but you don't feel like the problem is truly solved. And you're right. The medication is managing a measurement while three biological mechanisms remain broken. Your kidneys still can't regulate sodium properly. Your vessel lining still can't produce adequate nitric oxide. Your arterial walls are still progressively stiffening. The symptoms are controlled, but the disease process continues. Now, here's the question that actually matters. Can these three mechanisms be repaired? Can kidney function be restored? Can endothelial cells regain their ability to produce nitric oxide? Can arterial stiffness be slowed or reversed? This is where research from the past 25 years reveals something most people never learn. The answer is yes, but not with medication alone. Medication manages outcomes. It forces changes that improve the numbers. But specific dietary and lifestyle interventions can actually address the underlying mechanisms. They can restore normal function instead of just working around dysfunction. The landmark research was published in 1997 in the New England Journal of Medicine. Scientists tested whether a specific dietary pattern could lower blood pressure. They enrolled 459 people with elevated blood pressure. Some continued eating a typical American diet. Others followed what became known as the DASH diet, emphasizing fruits, vegetables, low-fat dairy, whole grains, and lean proteins while reducing saturated fat and sodium. After 8 weeks, the DASH diet group experienced blood pressure reductions of 11.4 points systolic and 5.5 points diastolic on average. That's comparable to first-line blood pressure medication. But here's what makes this different from medication. The researchers didn't just measure blood pressure, they measured endothelial function. They found that the DASH diet had restored the ability of blood vessel linings to produce nitric oxide properly. The vessels had regained normal function. The mechanism had been repaired, not bypassed. So what was in this diet that triggered repair? First, it provided approximately 4,000 microcalories of potassium daily, nearly double typical American intake. This amount of potassium appears to restore normal kidney sodium excretion. It quiets the and angiotensin-aldosterone hormonal system that was locking kidneys in retention mode. The kidney mechanism starts functioning properly again. Second, it provided adequate magnesium around 500 milligrams daily from vegetables, whole grains, nuts, and seeds. This magnesium provides the natural calcium channel blocking effect that had been missing. Blood vessel muscles regain their natural regulation. They can relax appropriately. Third, it included substantial antioxidants from fruits and vegetables. These antioxidants protect nitric oxide from being destroyed by free radicals. They also reduced the oxidative stress that was damaging endothelial cells in the first place. Fourth, it provided calcium from low-fat dairy products. Calcium activates cellular pathways that promote nitric oxide release. The combination of all these nutrients working together addressed all 3 broken mechanisms simultaneously. Kidney function improved, endothelial function improved, vascular reactivity improved. This is why the blood pressure reductions occurred, not because the diet was forcing a change, because it was providing what the body needed to repair itself. Now, let me be clear about what this information means for you. If you're currently taking blood pressure medication, this doesn't mean you should stop. Stopping medication abruptly can be dangerous. What this means is that you now understand the difference between managing a symptom and repairing a mechanism. Your medication is managing the symptom. It's doing that job. Keep taking it. But these dietary interventions can potentially address the underlying mechanisms while you continue medication. As the mechanisms repair, as kidney function improves, as endothelial function restores, as vessel reactivity normalizes, your blood pressure may improve further. At that point, working with your healthcare provider, medication dosages might be adjusted. Some people find they need less medication. Some people's blood pressure control improves while staying on the same dose. The goal isn't to replace medication. The goal is to fix what's actually broken so your body can function normally again with or without medication support. Additionally, you need to know that certain people require modifications to these recommendations. If you have kidney disease, potassium intake may need restriction rather than increase. If you take ACE inhibitors, ARBs, or potassium-sparing diuretics, increasing dietary potassium requires medical guidance to avoid dangerous potassium levels. If you have diabetes, dietary changes affect blood sugar control and may require medication adjustments. The path forward is implementing these evidence-based interventions alongside your current medical care, monitoring your response, and having informed discussions with your healthcare provider about what your body's response indicates. Now, you might be wondering if this research exists, if these mechanisms can be addressed. Why didn't my doctor explain this? There are several practical reasons. First, medical appointments are brief. Explaining these mechanisms thoroughly takes time that most appointments don't allow. Writing a prescription takes seconds. Second, many physicians trained in an era when medical education emphasized pharmacology over nutrition. That's changing in newer training, but many practicing physicians received limited nutrition education. Third, there's an assumption that patients won't follow detailed dietary advice. so doctors rely on medications with predictable effects. Fourth, the healthcare reimbursement system pays well for medication management but provides minimal compensation for comprehensive dietary counseling. None of this represents bad faith. These are systemic constraints in healthcare delivery. But it does mean that patients who want comprehensive approaches often need to advocate for themselves. You can bring research to appointments. You can ask specific questions about addressing underlying mechanisms. You can request monitoring as you implement dietary changes. Most physicians support patients who show genuine interest in evidence-based lifestyle interventions. The key is being informed so you can have productive conversations rather than just accepting prescriptions passively. So let me give you a practical roadmap. Step 1 is assessment. For 3 complete days, write down everything you eat and drink. Then calculate your potassium intake. You can find potassium content in online databases. Most people discover they're consuming 2 saline to 2,500 milligrams when optimal is 4,700. Calculate magnesium intake. Most people get 250 to 300 milligrams instead of the 400 to 500 needed. Identify your sodium sources, usually processed foods, restaurant meals, packaged items. This assessment shows you specifically what needs to change. Step 2 is gradual implementation. You don't need to transform everything overnight. Start by adding potassium-rich foods, bananas, potatoes with skin, spinach, avocados, beans, oranges. Add 1 serving daily, then gradually increase. Add magnesium-rich foods, dark leafy greens, almonds, pumpkin seeds, whole grain, breads, black beans. Build gradually. Reduce sodium by choosing fresh foods over processed, cooking at home more often, reading labels carefully for sodium content. These cumulative changes shift your nutrient ratios toward ranges that support normal function. Step 3 is adding movement. Aerobic activity like brisk walking for 30 to 60 minutes most days creates beneficial effects on vessel function. The key is consistency, not intensity. Step 4 is monitoring. Get a validated home blood pressure monitor. Take readings at the same time daily. Track the trend over weeks. This provides objective data about whether your body is responding.